Well, good morning, everyone. Thank you so much for joining us and for being here for our Distinguished Speaker Series 2020. We're very excited to have Dr. Anna Kulidjian join us today, and we're going to learn a lot about advances in hip replacement. So we're excited to be here today. Before we get any further, I would like to give a big thank you to Judy White, who is our sponsor and donor for our Distinguished Speaker Series of 2020. A big thank you to her. We're very grateful for the support. And of course, we're very grateful to all of you who continue to support us and attend our programs. Thank you so much for being here. And I do want to share a few screens with you. Of course, the end of year is nearing, and we would love to invite you to think and consider making a contribution to the community center. We, of course, are a nonprofit, and we serve seniors and adults in the community of La Jolla and the greater San Diego area as well. And we have a lot of programs that we provide daily as well as services. So we would love for you to consider making a contribution to our center today or by the end of the year. Again, we are a nonprofit and the contribution would be tax deductible. You can make a donation through our website or, of course, mailing anything into the community center. I also want to let you know that we have a wonderful holiday benefit concert coming up on Thursday, December 10th, featuring the Peter Sprague Trio. Of course, we would love for you to join us for that. More information is available again on our website. And one more slide I would like to share with you is regarding our free virtual classes and, of course, other offerings that we have available. Everything from cooking and other language classes, a lot of great programming. The free classes include anything from art and yoga and meditation. So I really encourage you to please join us and visit our website. It's ljcommunitycenter.org, where you can learn more. And before I tell you a little bit about Dr. Anna Kulidjian, I would like to encourage you to please use the chat or question function at the bottom of your screen. We'll be monitoring that during the presentation. So if you have any questions, please feel free to use that and we'll get to them at the end of the presentation. So a big thank you again for joining us. And I'm going to tell you a little bit about Dr. Kulidjian. She is an orthopedic surgeon with Scripps Green Hospital in La Jolla and is associate clinical professor and the director of the Musculoskeletal program at the Scripps MD Anderson Cancer Center. She received her MD from University of Toronto and completed fellowships in joint reconstruction and limb preservation in Mount Sinai Hospital and Princess Margaret Hospitals in Toronto. Dr. Kulidjian has been an orthopedic surgeon for the last 15 years and performs primary and revision knee and hip replacements using advanced technologies and minimally invasive techniques. She has extensive experience restoring limb functions through complex reconstructions. Dr. Kulidjian will discuss advances in reconstructive procedures, specifically focusing on restoration of hip function through modern techniques in arthroplasty. She recently introduced a new technique called ESY, Direct Anterior Approach to San Diego. Her research focuses on improvements in joint replacements techniques, including efficient knee and hip arthroplasty and robotics. Please help me welcome Dr. Anna Kulidjian.
Thank you so much. I don't know if you can see my screen, but I really appreciate you inviting me. It has a special meaning for me because I am La Jollan and my kids grew up or are growing up in La Jolla using amazing services that the community center provides, a place for us, all of us get together, maybe virtually right now, but hopefully soon again, the way our community knows how to do. I welcome any of your questions. I think it's really good to have this opportunity to speak to people, maybe hopefully not at the time when they're in pain, where you can maybe ask the questions in a more applicable way of how to improve the function and maybe even avoid a need for hip or knee replacement. So I welcome all of those questions, not just with regards to the surgical procedure itself, but any of those that you might have had. I'm going to talk for about half an hour, 35 minutes, and then we'll have plenty of time to discuss it in a very open way. And again, if you can use that function throughout while writing questions, we can go over them at the end, or I don't know if there's an opportunity to even ask them at the end yourself. So the technique that I'm going to be focusing a little bit at the end is a newer way of doing the old, same old. And we'll first talk about what is the hip replacement, how did it come about, what do we know about it, what is good and what is bad, what are the problems, and then I'll introduce to you a modification of how to do the same procedure, which we do really well, over 97, 98% success rate, to do it a little more standard, to minimize chances of things going slightly bit off. and how to do it more effectively so that the surgery is done in about 35, 40 minutes, so that there's not really that many people in a room, especially now with the COVID. And how do we make it even better, something that's so good already. So I don't have any disclosures for this specific talk. And again, the technique is efficient. It's called efficient direct anterior, that was developed by Professor Korten in Belgium and now has been popularized across the world. And we were just fortunate enough to be the first in the US, but there's a huge response to our technique and bringing it here. So this is, I think, something that we all know instinctively, but a good way to look at it, of number of people that are going to be over the age 65. And the significance of over the age 65 is that typically we thought before that the number of people needing hip and knee replacements fall into that group. Now we know that our implants improved and people are more active, so we do it even earlier. But I just brought this up to see that we're really facing this huge increase in the population that is eligible or needs hip and knee replacements. And yet our physician numbers and surgeon numbers haven't really increased at this pace. So we are facing a little bit of a problem that's coming slowly, but not so slowly toward us. So with that in mind, the numbers of people needing hip and knee replacements will be astronomical as compared to the resources they have. We have both surgical resources as well as financial resources to be able to afford well done surgeries. And just focusing on the hips, we're thinking we're going to need 700,000 to 1 million hip procedures by 2030. Total knees, 2 million procedures. So this is why we're so focused on how do we make it safer and more predictable. So we're not spending some people 2 hours, some people 3 hours doing a hip and knee replacement, but how can we teach something so safe and predictable that everybody can do it in a very predictable way? Plus, we know if we do it effectively and fast, the infection rate is less. So then the complications are less. So the surgeon is not really dealing with as many complications. And especially on the patient side, patient can go and return to normal life sooner. And again, support their life and support the economic life of the country. So today, there's only 300,000 of hip replacements. And you can see sometimes there's a wait and you're upset about it. But this is what the numbers were to show that we really need to start focusing on things today. So people often come to the office and ask, okay, so well, hip replacement, it comes anterior, posterior, anterolateral, what is best and what is not? I just wanted to say one thing, the hip replacement are the most successful surgeries as humans we've developed. So if the improvement rate is close to 99%, you can imagine that it doesn't really matter what approach you do. The anticipated outcome at 3 months is a very, very good one. So that's sort of right away, because there's a lot of worry, I have to have it this way, I have to have it the other way. This approach is just another way of doing it and provides a more standardized approach and perhaps a little bit faster recovery, which has been shown in the literature. But I want to assure you that if your surgeon doesn't know this approach, that is not, the end of the day, because it's a very, very good procedure. This is just a slight improvement on a type of that good procedure. So why are we doing hip replacements? What are the indications? Of course, the first one is arthritis. And actually, a lot of people say, well, what is arthritis? They kind of think it's a scary thing. But arthritis comes in different ways. And the specific bone or osteo, we call it, arthritis is just an arthritis of wear and tear. So if you had a car and you drove it a lot, the tire wears and you need to replace those tires sooner. If you didn't drive it so much, or maybe your car was the lemon, then okay, you need to replace it a little bit sooner. So this is what it is. It's just the joint is worn out, and that's called arthritis. And it's not a horrible disease like some other arthritis could be. And we can treat it by replacing a part that's involved. So that's the degenerative type of arthritis. Sometimes people don't have so much X-ray differences, but they're very, very stiff. So hip replacement can improve range of motion dramatically. Some people have the bad arthritis, and bad arthritis, I mean that they affect many, many joints, and that's the inflammatory type arthritis. Some people have a vascular necrosis where the bone actually collapses. The cartilage would have been okay, but the bone underneath collapses, and that's called a vascular necrosis, which is kind of a stroke of the bone. Again, sounds very scary, but it happens a lot. It happens because we use fancy medications that some of them have side effects. There's other unknown causes, some genetic causes, so that's another reason. TB has fallen off, but infections in general around the world are one of the common reasons why you need to replace joints. Some people have congenital problems, like their hip doesn't fit so well, the femoral head doesn't fit into the pelvis, and they need hip replacements. Of course, trauma from any kind of motor vehicle collisions or tumors. The first thing that the surgeon will do, or your primary care, they will offer non-surgical treatment. And why that's important, because we do know that our own joints are good up until to the point that they're really interfering with our function because of all those things that we talked about. So if you can, stay with the minimum pain, 1 to 2 with the occasional Tylenol or Advil, it's probably okay to delay it. And it's advisable to speak to your surgeon about what are your goals, what are you trying to accomplish. If you're in a wheelchair and you don't really need that risk of surgery, perhaps that's a good thing. Of course, if you're swinging golf clubs, if you're playing tennis, perhaps function comes even before the number of the pain score. We also offer physical therapy. It's known that strengthening the muscles around it, not really increasing the range of motion, but really strengthening the muscles around it, tend to provide less pain. There's often walking aids that will be offered. Of course, steroid injections, they're really, really good in the knee, not so good in the hip. So it's almost like a last resort. Like if you have a wedding to go to or something, maybe an injection would help. But the hips are not, once the biomechanics are off, it's not advisable to have many steroid injections. And then, of course, the total joint replacement. So if you see somebody who has a painful, stiff, disabling joint, and they've tried at least some effort with physical therapy and had some medications, I think that's a good indication. So what is a hip replacement? I wanted to show it to you. I don't think my marker works, but if you look, the hip is consisting of sort of 2 bones. The femur at the top has this femoral head, as you can see, and then the pelvis has the cup, the saucer, and it's the acetabulum. So the hip is composed of 2 bones, and both of those bones are covered at the end terminally by cartilage. And when the cartilage wears and the bone is trying to articulate with bone, it's not very smooth, and that's why we call it arthritis, for whatever the cause may be. So when we talk about a hip replacement, we're replacing the surface of the cartilage on the acetabulum, on the pelvic side. We're replacing the whole ball, because I'll show you, we tried not to replace the whole ball and the results were not so good. And I'll go a little bit into it. So we replaced the whole ball attached to the neck, and it gets pounded inside the hip. So there's not really, or inside the femur. So there's not really anything sticking out. Very little contact really to the metal itself. So some people are worried about allergy. I've never really treated thousands of patients, and hip allergy is not one of those things you see. So what is it that anterior, posterior, and all those approaches are? It's just a way to get to the bone to do the same surgery. Everybody's doing the surgery. We're just getting to the bone in different ways, and I'll talk about which ways we go. This is a slide that's going to put you probably above and beyond some even primary care physicians, not to entice you to feel that way, but people talk about hip pain and they point to these areas, right? So this is not the hip. This is actually your back pain. The hip pain is actually the groin pain. So this slide is a very important one. Even though we often in the community say, oh, my hip hurts, and point to here, this is actually a sign of a back pain, perhaps some bursitis. But if you don't have groin and deep buttock pain, it's probably not your hip. So that is it for a tip for today. This is an X-ray, so the radiographs are very, very helpful, and most hip arthritides can be figured from simple X-rays. So on the left to your screen is a regular hip. You can see it's very smooth. Look at the edges. The ball is smooth. Everything is covered. That hat, that saucer is on the top. It's covered. Once you have arthritis, there's 5 cardinal signs. All this white stuff, which is the sclerosis, the little bubbles you can see, the cysts, the deformity, the hip is coming out. You can see the hip is of a different shape. The cartilage space, that space between the bone, the gray stuff at the top and the ball, that black space disappeared. And those are what arthritis really is. And this is a type of a replacement. On the right is the hip replacement. And then the left is when we tried to replace just the cartilage. Remember I said we did that where we replaced just the cartilage, and we called it hip resurfacing. And that was unfortunately metal on metal. It was developed in London. And unfortunately, as you probably heard, a lot of issues came up with metal on metal. We'll talk about it a tiny bit more at the end. And that's why this is not a surgery that I recommend for most people. People often ask, what company name of the hip replacement am I getting? Probably the smarter question is, or the more important question for the outcome is what surfaces. So, what's touching what? And we talked about just a second ago, metal on metal. That's a bad word right now. So we're talking about hard on hard surfaces like metal on metal, for example, or hard on soft. And our body typically has hard on soft. And that's why I think hard on soft surfaces have lasted more, because our bodies bear with it more. So this is type of implants that are used around the world. The metal on metal is now really not being used by probably over 95% of people because of side effects of heavy metal poisoning, local toxemia to the cells, and possibly systemic reactions, which means the whole body would react to those metal debris. So what we use, we put a metal or ceramic instead of the bowl that we're replacing. Most people choose some kind of a titanium shell coating that goes into the acetabulum. And then in between, there's something like plastic, which is, we'll talk about it a little bit, which is soft, and it takes the blows, and we've really improved those plastics so they don't wear. And then more so in Europe, they're using ceramic on ceramic. We used to use a lot more, but there's a lot of controversy because of squeaking, right? So, and it's not a very comfortable thing. And I think we're much more active in many ways, and that is why it's really fallen out of favor in the US. So where did this techniques, where did it come from? It's actually really old surgery. Even in the early 20th century, people started playing with the idea of resurfacing, and they tried to put gold. Didn't last that long. It was done in 1923. They tried glass, where the glass mold would be placed into the hip. And unfortunately, it's like the ceramic, but it wasn't as high of a quality, and obviously it would break. Otherwise, it was a good idea. They even tried to put some kind of a paper type, celluloid type things. They didn't work until sort of, I think the first more successful one is 1937, where this alloy was used. It's called Vitalium. And interesting, this is truly till now, this plus some baby variations of the mix of metals has become the only one that lasted and seemed to have been very well tolerated by the body, and it's very strong, so it doesn't break. When people try to put a little more titanium on the femur, not on the acetabulum, it actually, obviously being that angled, broke and caused a lot of problems. Again, acrylic. Interestingly, even though metal on metal, this new thing, McKee and Farrar in the mid-century have come up with the same idea. It failed miserably, disappeared for a while, and then companies started bringing back, thinking that they can improve it with other metals. Failed the same way, caused a lot of problems. We're still removing them for revision surgery, which is quite sad. So if you do have a metal on metal hip replacement, please do go and check with the orthopedic surgeon. Make sure you're not getting any kind of metal ions in your body. So the true birth is probably 1950s. This is Professor Charnley. He started experimenting and performed the first hip replacement that replaced the acetabulum with polyethylene and femur with a metal head. And this, I trained in Toronto. We had people coming in who immigrated or came from England, and they still were walking on original Charnley hips 40, 50 years after. So well done hip. Doesn't matter, as long as it's that concept that we just talked about, they last a long time. This is an example of somebody, a patient of mine who, as you can see, had both hips replaced with the earlier type plastics. And I came here to San Diego in 2008, and this patient came to see me because, as you can see, the bowls are not centered anymore. You see, that's what happens. Everything stays, the metal stays, the screws stay, everything stays in place, but the plastics start wearing in some people. And perhaps this person had lots of medications and was very young, had rheumatoid arthritis, and that's why their hips wore out faster, but still I think it was 12 to 15 years old. So again, what are some things to do so that you put one hip on a person and it lasts forever? Because again, that way we're not redoing our old patients and in a way increasing the numbers of hips even further. So we found ways to improve polyethylenes so they don't essentially wear. Even at 12, 15-year studies, the newer type polyethylenes show no wear, and they're resistant to oxidation. So if you're on specific medications, hopefully it doesn't affect them. And they're very, very strong, so they don't break. And this is just a quick electron microscopy picture to show that we're just increasing this crosslinks, the density, so that there's no fatigue of the plastic, because the metal is going to last forever. So here is the standard plastic versus that highly crosslink in one of the companies, doesn't matter which one. All of them have, all of the big companies that are in the US have very, very good plastics, and you can see there's essentially no wear. Another thing we talk about is the hip dislocation. I mean, it's a very, very important thing. Their doctor will tell you that's not a secret, that some hips, even well placed, dislocate. And we don't really have quite a good understanding, but we did notice that approaches made a difference. So when people went posterior with 4% of dislocation, we could treat it. It's not a terminal, terrible thing, but it's painful and it's uncomfortable. And when we went anterior lateral, which is another European approach and Canadian approach that I used to do prior to the anterior, or this new anterior approach, which is again variation of the old, they had essentially no dislocation, 0.4%. And so people started looking for approaches. How do I get into the hip so it's not, so the hip is not popping out until soft tissues heal, right? So the less we cut, the less chance. What else did we do? Once the plastics improved, we could increase the size of the femoral head. Why? Because you can see, I'll show you a little bit later that to tie your shoe or do a lot of activities, you need a really big range of your hip. So of course, if the plastic needs to be thicker because we know that it's going to wear, then you can do a small femoral head, right? So at that, the picture here on the left shows that with a smaller femoral head, it's going to hit that saucer sooner than if you have a bigger femoral head. So with the better plastics and with better technology, we're able to increase the size of the femoral head so that people don't start hitting and popping out of the socket, especially in an early postoperative period over 3 months. So the goal is to bring the hips, and we're doing a very good job working with the industry, to the same shape and size as your natural hip. And we're very, very close to achieving that. So this is that metal on metal, just to mention, because there's still a lot of people in the community who unfortunately got it. It was very popular up to probably 8 to 6 years ago. And we're slowly, unfortunately, having to revise them. And it causes that, I told you about, essentially abrasion type reaction. It's not really abrasion, but the metal ions start spewing into the surrounding and sometimes systemically causing problems. And the ceramic, like glass, you know, it squeaks, and it's that uncomfortable squeak with the glass that you hear and you kind of cringe. Imagine that in your body. So it's not many people in the US are putting that in. This is that slide that I think is very interesting to see how deep you really need to squat to do some of the activities, such as tying your shoes or gardening. So that's why we're really trying to bring the heads bigger without going to metal on metal. The whole point of metal on metal was to bring that big femoral head so you're stable and you can do pretty much anything, except it didn't work. So now with improved plastics and understanding of biomechanics and how to change the wear characteristics of things we use, we're getting to that with safer way. So I'm going to talk a little bit about minimally invasive surgery. I think it was such a good word. You know, people thought about minimally invasive surgery, but it's not the size of the minimal incision that determines the minimally invasive surgery, because sometimes if your incision is too small, the amount of damage you need to do deep that you don't see is so high that it actually is not a good thing. But in a good way, if we're honest about what minimally invasive is how are we respectful of the soft tissues? Dr. Salter, who was my mentor, he was the inventor of orthopedic surgery, kind of a general surgeon who was one of the first orthopedic surgeons in the world who really moved the field forward. Would always say a really good surgeon behaves like a guest. You come to somebody's house, you leave it cleaner than you found it. You don't leave it messy. And that's what truly minimally invasive is. So you have to be appropriately minimally invasive, not fake inappropriate sort of small incision, big damage inside. So that's what really this technique is doing. And I'll show you how it does that. Because in a true setting, if you're not cutting many things, you can go home the same day. You can feel much better, less narcotics used. You don't need blood. And in long term, there's not really that much scarring. So there's people who just simply couldn't have minimally invasive surgery because they have maximal amount of soft tissue. And those are obese people who we talk about high BMI, or even muscular males. They're very, very fit, but they're weightlifters, so their muscles are so big, you can't really keep the incision small because all the bone is so deep. Remember I said the point is to get to the bone and be able to put all those things that I described to you in a way that's not going to cause a complication. So what this technique did, it just moved that bar a little bit, where it's not, I'm not suggesting we do surgeries in very, very large people, because that carries a lot of medical complications. But at least if there is appropriately chosen patient that otherwise is medically fit to have surgery, they can have successful anterior hip with minimally invasive techniques, which was not really possible before this. So these are the approaches. I think it's a very important slide. So the green is how we can get to the hip. The back one, the posterior one, is probably over 95% of US surgeons have been trained on it, even until now. It's a very, very good approach. That's unfortunately cut. It goes through the gluteal muscle to the butt, but then it has to cut a couple of muscles to get in, or tendons, to get into the hip. And we've now learned to repair them, reducing the dislocation rate. It takes a little bit longer time to heal them, but technically it should heal and there shouldn't be any problems. Anterior lateral approach is probably was the safest approach in terms of neurovascular damage, and it's sometimes like a workhorse. If you have a complex case, you can see the back, you can see the front. You're not really cutting into anything. You're splitting the muscles, but you're lifting them up, and again, you're relying on that time for it to heal back onto the bone. The anterior hip is probably provides the smallest window by itself. It's really reserved for primary hip replacements. And with some extension, you can do some revisions, but not all the revisions. But what it does, it truly doesn't cut anything except the capsule. All of these, the hip is covered by this very nice tissue. It's called the capsule. It's just sort of a scar bowl. And so if you cut the scar bowl heals. There's not really, pain is very minimal. And, but as you can see, you're going right next to that red, blue, and yellow thing. You see that in the corner? That's the nerve, the vessel, and the artery, femoral artery and vein, and they supply everything to your leg, right? Most of the muscle functions, and certainly the vascular supply. So the retractors become important, right? Because if the retractors are pushing on that, you get femoral artery thrombosis, you can get vein problems, and you can get the worst is the nerve problem. So the posterior approach maybe has a little bit of a sciatic nerve, but it's easily seeable. Lateral approach is super far from all the nerves and vessels, so it's very safe. Anterior approach is really, you better rely on a good assistant and good retractors, and that's the issue really. Otherwise, it's a great approach. So what this approach does, it removes the assistance. So the surgeon places the retractor and stays there. The assistant can't just like look up, or I don't know, fly flies by, God knows, something crazy happens. People have excuses, and then he moves, and that dings the retractor hits the femoral nerve, and then people have pain, or even worse if you have muscle function. So that's why the anterior approach was hard to teach, had lots of complications on the way to learning, but once you learn it, it's a great approach. So what this technique does, it really removes the variabilities, and you're only teaching one person, the surgeon. Really, the assistants are not touching anything, which is really great. So that might need another explanation, and I'm happy to do that at the end. So again, posterior we now are better because we can repair things. Anterior lateral really doesn't really cut anything, and you can do minimally invasive style, and anterior approach we'll talk a little bit more. And at 3 to 6 months, there's multiple studies. All approaches are the same. It's the rush to get it there faster. And yes, anterior approach does get you there faster in terms of pain and function. So this was the anterior approach that is still widely used in the US. It's Dr. Mata, a US surgeon, developed it. It's this big table. And you can see you have to stretch the leg kind of in this contrapture, and you're really strapped to the bed. If you move, something bad will happen. And you need assistance to move the bed, because the surgeon can't be touching it. It's not sterile. So you better have an assistant that knows what they're doing. You also need an x-ray because you can't really move anything, you can't see. It's just the patient is in the same position. It's a little bit an uncomfortable position. So you would have to choose people who are of a specific size that can fit on the table safely, and that you can move things around. And you need to cut a lot more capsule kind of, and you need that x-ray to be able to at least see some stuff. So it's a great approach. But as you can see, even though the scar may be minimally invasive, takes maximal effort. It takes a lot of people in the OR. So not only the assistants that are holding retractors, plus now an assistant who drives the x-ray machine and drives this table. And so you get radiation, the more people, COVID, it's just less plausible with the use of all of these PPEs even to have that many people in a room, but still a fantastic approach and has taught a lot of us a lot of interesting things. So what is this easy approach? It's not for easy as in easy, it's efficient surgery. It really removes all of the assistance. Obviously that minimizes the use of protective equipment, exposure, but also costs, right? So we're talking about, how do we afford this hip replacements in the future? And it decreases number of people you need, so therefore it decreases the cost. It decreases number of trays we need, so we're not sterilizing things. Environmentally, much more friendly. Time-wise, very predictable. You're much faster. Less soft tissue injury, so less infections, so you don't need to revise things as much. And all of these are published by Dr. Korten in over 2,000 series that he's published, and truly helps the patient, helps the healthcare system, helps all of us to get the job done and go back to fun and enjoy ourselves. So I'm going to show you some slides that there's no surgical crazy slides, but this is from Professor Korten with his permission to share in Belgium. And the patient basically is brought in, placed on a table. Nothing fancy is going on. You clean everything. Patient is really not moved. So anesthesia is easy. Sometimes people don't even go to sleep. They just do a spinal. And while they're sort of chatting up with the anesthesia, the hip replacement can be done. And this is his patient that had both hips done. Again, you can do both hips at the same time because you're not really being moved. You're just laid there. The retractors do the job. So you start on one side, and that basically you put these static gripper holders that are next to the patient, and that's it. Those are your assistants. This is a drape that just literally, he invented this drape. Look how amazing it is. It just comes on, and there's 1 minute that's spent to draping. Usually, in my cases, we're spending 20 minutes. The windows open up, so you can do both hips at the same time, as you can see, and essentially not even move the patients. And you can see the patient is just getting some oxygen. That's kind of really cool. These are the grippers. These are a little bit blood here, so please don't look if you don't like it. But basically, the retractors get placed, and then you can continue hip replacement through, as you can see, a small bikini incision. Patient is not really doing anything, just laying there. You saw the leg position, and nothing really is going on. It's just the case keeps going. And the surgeon is operating. There's not really additional people. Again, a little bit of blood. I apologize. As you can see, the retractors, once the surgeon places them, the one on the left is the fellow. Usually we have a fellow as well. But once we place the retractor, they're held, and there's 3 people, the nurse that's passing the equipment, the fellow that's learning, and the surgeon. That's it. This is and you're laying there. Pretty cool. So again, just showing how easy things go. And again, just a summary that there's not really people needed, and everything is done by a little piece of a retractor holder. So again, so what are the advantages or changes? Every approach is improving. There's believers on every approach. The posterior approach decreased the number of dislocations with better repair of the muscle. The anterior lateral is now even less invasive. Anterior approach, we have a HANA table in US, which is very widespread. In Europe, this is just taking everything by storm. And after I brought it in here, I was invited to a panel, and one of the big companies has, in fact, applied to bring this across US and start teaching it, including bringing surgeons to our center and doing cadaveric training. We've now done over probably close to 100. I taught my fellow partner, who's an excellent surgeon, he just joined us this year. And together we've probably done close to 150, perhaps even close to 200 patients. And again, remember I told you, I'll be very honest, whenever you're learning a new technique, the first 50 usually have complications, and we did not have any. And that is not because, oh, we're such good surgeons. We're very, very good surgeons, like many of our colleagues, but it's the technique is, as you can see, is using the surgeon. What we do best, we've been trained to be good surgeons, but we're using our skill to place things, and we're in control. And therefore your surgeons who you've selected is doing your surgery kind of by their hands. There's no table, there's no pulling, so that's why the complications are less, because you're feeling everything by you're putting a retractor, you're really attached to that body, you're inside that body, it's your responsibility. It's a beautiful thing to be a surgeon, because you realize the responsibility, but that by giving the control to the surgeon with this technique, I think we're allowing the surgeon to shine and to be the best. That's why I think less complications. So that's my take on it. So there's not really official US name. There's no sexy name. We always come up with the best names. I'm sure we will. But European surgeon who invented it, he called it efficient direct anterior. Again, it uses that suspended retractors that you just saw. I think you're the first US audience that saw the retractors now in action on the screen. And this is my email. It's my work email. But if there's any questions, I think now is the time. We'll go over them. But of course, I'm happy to talk to you in person. You can, I practice at the Scripps clinic next to Torrey Pines Golf Course. Fantastic, beautiful place from looking out at the golf course right now. And come in and we can talk some more. But here's back to you for questions.
Thank you so much, Dr. Kulidjian. That was fascinating, and we're very lucky to have you here in San Diego. Thank you for being here and sharing this technology with us. It was fascinating. I have a question for you from a member regarding the new method. She said, what are the side effects or challenges that you may face, and what is the risk of infection?
So we have not had any infections yet, right? But it doesn't really matter because we've only done 200. But typical risk of infection is hospital dependent, and our hospital runs about 0.2, which is very low. Imagine we're the 11th best group in the US, or 10th actually this year, and it's a hospital dependent phenomenon, right? So with his technique, so his published rate was in his hospital 0.2 to 0.4 in Belgium, but the 2,000 hip replacements he's done with this technique, he did not have infections. We think, and again, I talked to our colleagues in infectious disease, that when the soft tissue is not traumatized, your soft tissues don't care that there was bacteria on the skin after surgery. Of course, we all have bacteria on the skin, but they don't have a chance to get in because your immune system is functioning normally. Does it make sense? So it's not that the surgery is going to be clean. It's not really that happens in the surgery. It's the ability to fight the small amount of bacterial colonization, even despite your own washing, that may seep through the skin. And that, I think, is what's changing, because the skin is healthy, the muscle is not touched, everything kind of falls into place, and nothing was really pushed and pulled. Because of that, I think our infection rate remains low or non-existent so far, with a very small amount of patients. But then his infection rate, I think, is very telling. 2,000 with no infection is almost hard to believe, and most surgeons wouldn't believe. But I was there and I saw it.
Wonderful, thank you. There's a question. Is it necessary to have physical therapy post-surgery? If yes, for how long?
I think it's a very complicated question. Every single surgery after hip replacement, I say yes, because you have to recover those muscles. It's been a very interesting sort of awakening with this technique, because people are coming back and saying, well, why do I need therapy? I'm doing things better than I was doing before surgery. And they're saying that within 3 to 4 weeks. So I don't have a good explanation on how much therapy you need yet. But what I do think is good to have, you go home the next day or the same day, depending on what you want to do. But it's good to have like another person come and kind of encourage you to get up and maybe feel safe. Maybe, look at the wound and yeah, we don't have right now any infections, but maybe it's just a good thing to have somebody to maybe teach you walk better, because a lot of people are kind of crouching and because their hip hurts or their back hurts because their hip is stiff. But after surgery, you kind of get this new lease on life, and maybe having a therapist come and teach you to walk better, get maybe that fear of falling out of you. I think it's a very, very good thing. So for pain, we used to need physical therapy for pain. I can't really say it helps because the pain has decreased. It's still painful the first 2 weeks, especially. Some people only 2-3 days, but most of, I'd say you have to expect normal recovery of 2 weeks at least. And so maybe having therapists come to your home, assess your home. Are there stairs? Are there some loose carpets? Is a good idea. So do we need it for a long term? Most people that I've operated on elected not, actually all of them pretty much elected not to go for as long as they used to go, which is at least 8 weeks.
Wonderful, thank you. There's another question. Will I be able to walk in my house right after surgery?
Yes. Yeah, I think unless you had a complication, which we always have to, you would know. We tell you right after. You're able to walk within a couple of hours. As soon as you're sort of fully awake, you're walking, you're using a walker. As soon as you get comfortable from that, you're using a cane. And within, and again, the therapist might be helpful to tell you, okay, well, you're ready to not use a cane. But yes, you're walking with a walker.
Great. Gloria, I see you're unmuted. Do you have a question?
Can I just speak?
Yes.
Oh, well, I wondered,
Okay, I can give you a call and give you the information.
is it necessary these days to have a COVID exam before an appointment, before the surgery?
Yes, I think we in Scripps Green have instituted sort of a COVID bubble. So anybody who wants to have surgery a day, 24 hours prior to admission, gets a COVID test. So sometimes the morning off, depending on factors, and that you cannot really enter the hospital before that. And I think it's a safe way of doing it, so we don't have to run into problems. We have a separate floor dedicated for joint replacements, and anybody who enters it has to have a negative test. Which is organized when you come in for your preoperative appointment to see your anesthesia doctor. So it's actually easy.
I want to give a big thank you again to Dr. Kulidjian for being part of our Distinguished Speaker Series, to all of you for attending. We will be again posting this on our YouTube channel, and we will post Dr. Kulidjian's contact information if you have any further questions. So a big thank you, Dr. Kulidjian, and everyone have a great day and stay safe.
Thank you.
Bye-bye.